Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be going over postpartum nursing. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now so you don't forget. Subscribe to my channel if you haven't done so already. And don't forget, guys, I'm now offering next generation NCLEX reviews. You can reserve your spot for an NCLEX review or a one-on-one tutoring session or consultation session by visiting my website, nexusnursinginstitute.com. While you're there, be sure to check out the audio lessons I have available. The audio lessons are made specifically for current nursing program students, I should say. So students who are still in the program, but it's not looking good. You have to get a really high grade on your next exam to pass. I made those audio lessons specifically for you. I go over the most important things you need to know for your next exam, so be sure to check out the audio lessons. Also, guys, almost daily, you can find me covering a variety of nursing topics across my social media platforms, so be sure to check me out, Nexus Nursing, on TikTok, Instagram, Facebook, and YouTube. All right, guys, without further ado, let's get started. Postpartum nursing. First question. So your postpartum patient is diagnosed with cystitis. What is going to be your priority nursing intervention? Is it going to be to give a sitz bath? Are you going to encourage fluid intake? Are you going to place ice on the perineum or monitor the H&H lab values? H&H is hemoglobin and hematocrit. So your patient has cystitis. What are you going to do? What's the most important nursing intervention? Okay, most of you guys chose the correct answer, encourage fluid intake. I see 8 of you guys chose H&H, 6 of you chose cystitis. So let's talk about this, guys. So cystitis, guys, that's inflammation of the bladder, and it's almost always caused by an infection, okay? So patients got an infection, it's causing inflammation of that bladder. The priority nursing intervention is going to be to encourage fluid intake. Why? You want to flush out the bladder. You want to flush out the bladder because guess what? Your bladder is supposed to be a sterile environment. Okay. And so those pathogens, those microorganisms that are clinging to that bladder wall, once you're drinking fluids, you're flushing out that bladder and the patient urinates and boop, by pathogens, right? They can't stay in the bladder to reproduce and just to grow. So that's number one. You want to encourage fluid intake. Which teaching is incorrect about postpartum mastitis? Which one's wrong? Breast pads should be changed frequently. Hands should be washed before breastfeeding. Nipples should be washed daily with soap and water, or breastfeeding should occur every 2 to 3 hours. Which one is incorrect? If you're on the live and you weren't able to join the class, just put your answers on the live. You can still participate. Okay, very good. Most of you chose the correct answer. Nipples should be washed daily with soap and water. That is false. So let's talk about mastitis, guys. Mastitis, that's an infection of the breast tissue. This is very painful, and it usually happens between the 1st to 3 months of breastfeeding, right? Now, remember, I told you this is an infection of the breast tissue. Well, if the patient uses soap and water daily, we know that soap is very drying. Soap can cause cracking. Guess what? Your skin is the first line of defense. So if the skin has been there's a crack or there's an opening, that's a perfect medium for bacteria to set in and make the mastitis even worse. So all of the other choices are great things to teach the patient about mastitis, but not to use soap daily. Absolutely not. Your postpartum patient has a firm fundus and excessive bleeding. What's going to be your next action? Is it to document the findings, call the healthcare provider, massage the fundus, or place the patient in Trendelenburg position? So the patient's fundus is firm and they have excessive bleeding. What is your nursing action? This is amazing. 18 of you guys chose massage the fundus, and on the live, you guys were so confident choosing massage the fundus. Let's go back to the question. I want to point something out to you. It says the postpartum patient has a firm fundus. The reason you massage the fundus is because the fundus is boggy, it's soft, and we want it to be firm. We want contraction of the uterine muscle. In the question, it says that the fundus is already firm. Why are you massaging? If that fundus is already firm, and the reason that we massage the fundus is to make it firm, why are we massaging the fundus? It's already firm. The correct answer is to call the healthcare provider. Look at the question. Your postpartum patient has a firm fundus and excessive bleeding. So they're bleeding excessively despite that fundus being firm. So guess what? Chances are the cause of bleeding isn't the fundus because it's already firm. Something else is happening. Maybe, there's cervical laceration. We don't know. But what we do know is that there's nothing we can do now, because what we normally would have done was massage the fundus, but that fundus is already firm. So we're either going to need some type of pharmacologic, some type of medicine to intervene, or that patient's going to need surgery. Either way, you have to call the healthcare provider. Okay, guys, I don't want you guys to fall for this trick. And I did that on purpose because you're so used to hearing me scream, massage the fundus, but you have to know why and when you're massaging the fundus. It has to make sense, okay? All right, moving on. Select all that applies. So which instructions would you give to the postpartum patient with mastitis? Select all that apply. Guys, remember, select all that apply. You have to treat them as true or false. So your patient's got mastitis. What are you going to teach them? Here are your choices. Wear supportive bra. Rest during the acute phase. Increase fluid intake. Continue breastfeeding if the breasts aren't too sore. Take antibiotics until the soreness is resolved. Avoid decompression of the breast by breastfeeding or pumping. Those are your options. What are you going to teach your patient with mastitis? Okay. Very good. Let's talk about it. Obviously, we talked about mastitis, infection of the breast tissue. You want them to wear a supportive bra. You want them to rest during the acute phase where it's the worst. You want them to increase fluid intake. We always want to increase fluid intake when patients got infection. The only exception to this rule is if the patient has a diagnosis where we can't increase fluid intake, something like CHF, right? But generally speaking, we want to increase fluid intake, especially if there's infectious process present. We're going to teach the patient to continue breastfeeding if the breast is not too sore. Why? We need to decompress that breast either through breastfeeding or pumping. Okay, so all of those are true. The two wrong answers are going to be to take antibiotics until soreness is resolved. It's very important, guys. Make sure you're reading the entire question, because this is how NCLEX tricks you. They'll give you a beautiful answer at the beginning. A couple words will be correct to make you jump on it, to make you pounce on it, and then everything else is wrong. Take antibiotics, that's fine. But until the soreness has resolved, no, you take antibiotics as ordered. You take the entire complete dose of antibiotics. So that's why that's wrong. And then last, avoid decompression. No, we don't want to avoid decompression. We want to decompress the breast, right? We don't want engorgement. We want to decompress the breast by breastfeeding or pumping. Your postpartum patient's fundus is soft and boggy. What is your initial nursing intervention? Are you going to elevate the legs? Are you going to encourage voiding? Are you going to massage the fundus? Or are you going to push on the uterus? What are you going to do? Okay, very good. Now you massage the fundus. Why? Because it's soft, it's boggy. You're going to massage it so it can become firm, so we can have, you can expel some clots, and also, most importantly, cause contraction of those muscles to decrease bleeding. Okay, it's very important. Make sure you know when you're going to massage the fundus. You're not going to elevate the legs. That's not going to do anything for that bleeding. And encouraging voiding. Let me tell you something. You would encourage voiding if you saw the fundus was deviated. If it was deviated to the side, then you suspect that the patient's bladder is full. Then you're going to encourage them to void. But when it comes to the fundus being soft or boggy, your first nursing intervention is going to be to massage the fundus. Now, the last choice of push on the uterus, you don't do this, guys. You might cause inversion of the uterus, or you might even cause hemorrhaging, or both. So you are definitely not going to push on the uterus. You're going to massage the fundus. Your patient just had a C-section. Which would you encourage to prevent thrombophlebitis? Would it be to elevate the legs? Would it be bed rest? Would it be frequent ambulation? Or would you apply moist packs to the lower extremities bilaterally? What would you do? Your patient just had a C-section and you want to prevent thrombophlebitis. Okay, so let's talk about this. The correct answer is frequent ambulation. So I want you, let's talk about this. So thrombophlebitis, guys, this is like inflammation of the vein that's caused by a clot. And I want you to think about it. The patient just had a C-section. A C-section is an invasive procedure. Whenever a patient's having an invasive procedure, we don't care what type of invasive procedure it could be. It could be a C-section, it could be an appendectomy, it can be anything, right? Amputation. If the patient's having an invasive procedure, you're going to have three top concerns. What are those three concerns? Number one, infection. Number two, that patient developing a clot, a DVT, that DVT moving, the clot moving, going to the lung, causing a pulmonary embolism. And number three, hemorrhage. Those are our three biggest concerns, right? So patient had a C-section. The fact that they had a C-section, we know that's invasive procedure. We're already thinking about those three. And then the question goes on to say, which would you encourage to prevent thrombophlebitis? So we want to prevent a clot from causing inflammation of a vessel. Well, guess what can cause thrombophlebitis? Decreased circulation. Because when blood doesn't move, it does what? It clots. It causes thrombus, and that thrombus could cause inflammation, irritation of that vessel. So guess what decreases the chance of clot formation? Ambulation. When that patient's moving around, blood is circulating. With increased circulation, the chances of clot formation is decreased. That is the correct answer, guys. We want to prevent thrombophlebitis, movement, ambulation. What is the treatment for DVT? What is a treatment for deep vein thrombophlebitis? Would it be NSAIDs? Would it be aspirin? Would it be ibuprofen? Or would it be anticoagulants? Okay, very good. Almost everyone chose the correct answer. It's going to be anticoagulants. If the patient already has that clot that's causing that inflammation of the vessel, you're going to give anticoagulants. You want to break down that clot. Okay, the patient already has that DVT. Now, somebody on the live just asked a question. I'm not sure who it was, but the person said, for the prevention of DVT, Pretty Stinson says, usually after surgery, they have on SCDs, and Pa ISSR said, would SCDs be a better answer? Let me tell you something. If you have to choose between SCDs and ambulation, what are you going to choose? It's going to be ambulation. Think about it. If you can get the patient walking around, ambulating, where we have contraction of the muscles pushing against the vessels, the blood is circulating, right? We have them doing that. They're being active. That helps them with prevention of DVTs. It also helps their respiratory status. It helps prevent all types of other issues versus them just being in the bed with STDs. STDs are great. This is something we're definitely going to put on the patient after surgery. Absolutely. But there's no question between the two, it's going to be ambulation. That is the best thing for the patient to be up and moving about. Thank you for that question. That was a wonderful question. Select all that applies. Education on thrombophlebitis should include, remember, select all that applies. You're going to treat them as true or false. Here are your choices. Always massage the leg, always cross the legs, avoid prolonged sitting, avoid constrictive clothing, avoid ambulation, encourage ambulation. What are you going to teach your patient about thrombophlebitis? Always massage the leg, always cross the legs, avoid prolonged sitting, avoid constrictive clothing, avoid ambulation, encourage ambulation. Okay, very good. Let's talk about this. Always massage your leg. Absolutely not. Absolutely. Listen, guys. When it comes to nursing, unless you are massaging the fundus, we're not massaging anything, right? Patient has a clot. Do you mean you want to dislodge that clot and make that clot go to the patient's lungs? And now we're dealing with a pulmonary embolism, which is a medical emergency? Absolutely not. So we're not going to choose that. Always cross the legs. Guess what? When you're crossing the legs, you're applying pressure on the vessel, which decreases circulation. And we know with decreased circulation is increased risk of what? Clot formation. So we don't want that patient crossing their legs, right? And your second clue was the word always. As a nursing student, let me tell you this right now. When you're looking for an answer, if your answer has an all-inclusive such as always, never, only, stay away from it. That is not the correct answer, okay? Let's keep going. Avoid prolonged sitting. That's true. We don't want the patient being a couch potato and sitting forever. Why? Because when they're not moving, blood's not circulating the way that it's supposed to. And guess what? That increases the chance for clot formation. We want the patient moving about. We want them to be active. We want them to ambulate. So that's true. Avoid constrictive clothing. That's true as well. We don't want anything applying pressure on the vessels, slowing down circulation. Remember, when blood slows down, it does what? It clots. So we want to increase circulation. That's why we want the patient moving about. That's why we want them ambulate. That's why we want them ambulating. We don't want constrictive clothing. Absolutely not. What about avoid ambulation? That's false. We want them to ambulate, and that's why we want to encourage ambulation. Your postpartum patient develops sudden chest pain. Heart rate and respiratory rate is increased, and you suspect a pulmonary embolism because you massaged their leg, and now you cause them to have a pulmonary embolism anyway. What's going to be your nursing action, your first nursing action? Are you going to start an IV infusion? Are you going to assess the blood pressure? Are you going to give them morphine as ordered, or are you going to give them oxygen as ordered? What is your first nursing intervention for a patient you suspect with pulmonary embolism? Very good. You're going to administer oxygen as ordered. Everything else, guys, we can do later, but number one is going to be giving the oxygen because, again, pulmonary, that's the lungs. Something's wrong with the lungs. Pulmonary embolism, the patient now has a thrombus. They have a clot that has now lodged most likely in the pulmonary artery, right? And we have to increase oxygenation perfusion to this patient. Let me say this to you. When you guys are studying or you're looking at a test question and you see both the heart rate and, oh, you can't see my finger, the heart rate and the respiratory rate, both of them have increased together. That's never good. That is never good. Whenever you see the heart and the lungs trying to compensate together, you're seeing tachypnea and you're seeing tachycardia together. That usually lets you know the patient's not getting oxygen because of whatever reason. Maybe the patient's hemorrhaging out. Remember, oxygen's carried in hemoglobin. Hemoglobin is carried in the RBC. RBC is carried in the blood. So obviously, if that patient's bleeding out, the O2 level is going to be low. It could be that. It could be a DVT. It could be a PE. There could be many reasons. But whatever it is, we know there's decreased oxygen when we see these two together. Usually is decreased oxygen. So the most important thing for you to do is to increase oxygenation. You want to increase perfusion for your patient. Select all that applies. You just administered an anticoagulant to your patient. Which adverse reaction would you assess for? Select all that applies. Again, guys, how do we treat select all that apply? We treat them as true or false. Here's our choices: hematuria, ecchymosis, epistaxis, vertigo, headache, dysuria. You just gave an anticoagulant. What are the adverse reactions that you would be watching out for? And guys, whenever you're thinking about an adverse reaction of a medication, I want you to think about that medication's indication. Why we're giving this medication? What do we expect it to do? And then I want you to think about what happens if that medication works a little bit too well. If it works too well, what can happen? And that's going to be adverse reaction. Okay. So here's the correct answers. Hematuria, because if it works a little bit too well, now the patient was clotting too much, right? We're trying to get rid of the clots, but now that medication is working too well, and now they're doing the opposite. They're bleeding, and now we're seeing blood in the urine. That's an adverse reaction of this medication, hematuria. Or we're seeing ecchymosis. We're seeing bruising, that patient bleeding through the under the skin. That is an adverse reaction of an anticoagulant. Epistaxis, nosebleeds, right? Patients bleeding through the nose. That is an adverse reaction of anticoagulant. Not vertigo, not headache, not dysuria. Again, guys, always think about that medication and what happens if it works a little bit too well. So for example, let's say you're giving insulin. What would be an adverse reaction of insulin? Well, obviously, it's going to be a hypoglycemic reaction. We're giving insulin to lower the blood sugar, but if that insulin works a little bit too well, that patient's on the ground. We cause that patient to have a hypoglycemic reaction. So that's how I want you to think when you're looking for adverse reactions of medications. True or false? In the first 24 hours after birth, the uterus will feel like a firmly contracted ball about the size of a grapefruit. Is this true or is this false? True. This is absolutely true. And the uterus will be at the level of the umbilicus. Only 7 people answered. Where's everybody else? Oh, I see on the live, you guys say you lost connection. Were you able to get back in? Frozen, lost connection. Oh, I'm so sorry. We got to keep going. Okay, guys, you guys can follow along on the live. I'm sorry, I don't know what happened. Let's keep going. One more question anyway. We're almost done. I'm lying, 2 more questions. Your patient just had a C-section 2 hours ago. She's restless, thirsty, and has cool, clammy skin. What do you suspect to be happening here? Would it be hypertension? Would it be bradycardia? Would it be hypovolemia? Or would it be epilepsy? Patient just had a C-section 2 hours ago. They're restless, they're thirsty, they have cool, clammy skin. What do you think is happening here? That's right. Hemorrhage, hypovolemia. They're losing, they may be losing a lot of fluid, but usually it's blood, right? Hypovolemia. When you check the blood pressure, you're going to see the blood pressure down. When you check the labs, you'll see the H&H down. You'll see the RBCs down, right? When you look at the vital signs, you'll see the heart rate and respirations what? Up. When you look at the urine output, you're going to see the urine output what? Down. Remember, urine output should be at least 30 mLs per hour. If that patient's hypovolemic, you're going to see the kidneys are going to start to shut down. You're going to see the urine output decrease. So anyway, we got lots of clues. Number one, they told us the patient had a C-section, which means they had an invasive procedure. The fact that a patient had an invasive procedure, we don't care that it's a C-section, it could be any invasive procedure. Automatically, because we know they had an invasive procedure, we're going to be looking for answers that have something to do with hemorrhage, them losing blood, which was our answer. Infection, which is when you're going to be looking for, increased WBCs, foul odor, mucopurulent drainage, stuff like that. And last one, a DVT, patient having pain or tenderness or warmth in one of the lower extremities, the calf or the foot, or even a pulmonary embolism, that thrombus going to the patient's lungs. And now the patient has shortness of breath or, dyspnea, anxiety, coughing. I keep saying this, guys. Please commit this to memory. Whenever a patient's having has had an invasive procedure, in the back of your mind, before you even finish your question, you need to be thinking about those three things. Okay? Hemorrhage, infection, and DVT/pulmonary embolism. And that's our correct answer, hypovolemia. Look at the other choices. First, hypertension. Hypertension would be if the patient had too much fluid, right? Bradycardia, nope. If the patient is losing fluid, we're going to see the heart rate go up. We're going to see the respirations go up. We're going to see the blood pressure go down. Patient's going to have hypovolemia. And of course, epilepsy, that's incorrect. We're not going to expect to see the patient going into seizures. There's no reason for that. Okay, now this is the last question. Select all that apply. What are the predisposing risk factors or causes for postpartum hemorrhage? What would put a patient at risk for postpartum hemorrhage? Select all that applies. Here are the choices: uterine atony, laceration of the vagina or the cervix, retained placental fragments, prolonged labor, having a history of postpartum hemorrhage, infection. What are the predisposing risk factors or causes for postpartum hemorrhage? Again, uterine atony, laceration of the vagina or cervix, retained placental fraction, I can't speak, retained placental fragments, prolonged labor, history of postpartum hemorrhage, and infection. What do you guys say? All of them. All of them. If you're currently taking OB, make sure you know these risk factors. I guarantee you're going to see it again. I guarantee you're going to see it again. All right, guys, you did a great job. Let's see who got first place.